welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries and Trees section of the ACCP Communities website.
Today we have Nick Seabury from the University of Cincinnati Medical Center. He's a PGY2 emergency medicine resident. They'll be presenting on the comparison of the efficacy of oxymetallazine, tranexamic acid, and epinephrine lidocaine combination in the treatment of epistaxis.
All right, thank you for the introduction. I'm excited to talk with you all today about nosebleed knockout, a showdown of topical epistaxis treatments. Myself or any of the planners for this activity have no relevant financial relationships to disclose. Unfortunately, I do disclose that I utilized AI for the naming of the presentation to help with the catchy title, so hopefully that worked. The objectives for today's presentation will first briefly discuss epistaxis pathophysiology, just so we're all on the same playing field. Then we'll differentiate between types of epistaxis. And then finally, we'll jump into the recent publication regarding emergency department management of epistaxis. So the official definition is bleeding from the nostril, nasal cavity, or nasopharynx. Epistaxis is often referred to as just a nosebleed, so I'll use those terms interchangeably throughout today's presentation. It is relatively common. Around 60% of people will experience a nosebleed in their lifetime. Fortunately, only around 10% of those will require a medical intervention, so relatively common emergency department chief complaint, specifically in the extremes of ages. So nosebleeds and epistaxis can originate from the anterior and posterior area of the nasal cavity, which I think I have pictures on the next slide. And then again, the extremes of ages, so 5 to 10 years old, and this is usually due to like digital manipulation, messing with those like frail vessels in the anterior cavity. And then 50 to 80 years old, I think of this as patients that are vascular becomes more fragile with age, and also potentially like chronic nasal cannula use and those kinds of things can agitate those vessels. So as I said, anterior and posterior, just like it sounds, front versus back. Anterior accounts for the majority of nosebleeds, and most of these originate from this Kiesel's box plexus, which you can see here. It's just in the very front, so we have the nares just above the lip, and that vasculature right here is what causes the majority of the anterior epistaxis. And again, this is due to relatively fragile mucosa, any environmental changes, so particularly like cold weather, cold, dry weather, even like hot, dry weather can potentially precipitate this. And then posterior, again, is further back into the nasal cavity. So like the nasopharynx, this is where these arteries come into play, so the posterior ethmoid artery. And this typically has to have, I guess, associated with a comorbidity. So patients with uncontrolled hypertension, any use of anticoagulants, antiplatelets, or vascular abnormalities, both physical as well as like any coagulation cascade abnormalities. So local causes of epistaxis, the digital manipulation, which I mentioned, patients using their fingers to potentially irritate and cause nosebleeds. Any trauma, as well as the chronic nasal cannula use, can contribute to specifically interior nosebleeds. Systemic, so the uncontrolled hypertension, the patient that has alcohol use disorder, alcoholism, and then any coagulopathies, which could potentially make bleeding easier to occur and harder to stop if it were to occur. Any allergies or dryness, so specifically if patients have to use like they're blowing their nose a lot, or if it's just generally dry, cold, those can all contribute. And then finally, being pharmacists, we love our medications, so NSAIDs, obviously any anticoagulants or antiplatelets, and then illicit drugs. I think of things that are used or ingested through the nasal cavity as being higher risk in this situation. So there are some guideline recommendations. I think it's like human nature and intuition that if we are bleeding from our nose, whether it's ourselves or a loved one, we need to stop the bleed, and we know how to do that, just apply pressure. So our guideline recommendations from the otolaryngology head and neck surgery recommend that nasal compression with or without the assistance of the patient, so provided by a healthcare provider or the patient, for at least 5 minutes. The bleeding persists, then we can consider nasal packing, so there's rhino rockets and those kinds of things, to allow for more targeted and sustained pressure to help hopefully achieve hemostasis. And then finally, this is where our topical vasoconstrictors get the mention. So a relatively broad recommendation where appropriate interventions for the identified bleeding site. And this is where the topical vasoconstrictors, any nasal cautery, or moisturizing and lubricating agents can be applied. And typically, if it progresses past that, then we need to engage our ENT colleagues to potentially do a more targeted intervention. So that brings us to this journal that was introduced before, so I'll just cruise on by. So this was a prospective single-center observational cohort study conducted from February 2022 to May of 2024. Their primary outcome was percent cessation of bleeding, and they defined this by, which may seem obvious, but the absence of nasal or postnasal bleeding, and then patients must also deny any blood flow into the throat, and then no accumulation of blood into the mouth. Secondary endpoints they looked at was time to achieve hemostasis, and then they also evaluated recurrent visits within 72 hours. So they included adult patients that presented to the emergency department with non-traumatic epistaxis, so kind of like spontaneous or no obvious reason as to why they have a nosebleed. For exclusion, they excluded our vulnerable populations, if there were any known allergies to administered medications, they had a history of nasopharyngeal trauma or surgery within the last month, congenital coagulopathy disorders, if they had uncontrolled hypertension at baseline, which was defined as blood pressure that it was greater than 200/120. Then obviously if the patient refused treatment or left like AMA prior to receiving the appropriate treatment, they were excluded or withdrawn from the study. The statistical analysis, they did a power analysis to detect a statistically significant difference, which they defined with an alpha level of 5%. So using an 80% power, calculated a sample size, and then they increased, I guess accounted for like a 20% dropout rate. So they concluded that 284 patients would be needed in the medical treatment group, which was the patients that were not randomized, that received topical vasoconstrictor therapy. For independent continuous variables, they used the Mann-Whitney U-test or Kruskal-Wallis, and then chi-square or Fisher's exact test for categorical variables. And then they did apply this Bonferroni correction, which allowed for correction for multiple group comparisons. So jumping into the interventions, you can see that there were 3 topical therapies that were studied and looked at in this trial, and they used the Bonferroni correction to appropriately do statistics. So interventions, each patient received direct pressure for 15 minutes. And notably, this is a little bit longer than our ENT guidelines recommend. So they recommend for at least 5 minutes. Each patient had direct pressure applied for 15 minutes, and this is with or without the help of the healthcare provider. Epistaxis persisted, then topical therapy was utilized at provider discretion. So you can see our topical therapies here. And then finally, if topical therapies did not achieve hemostasis, then ENT was consulted for refractory epistaxis and to intervene more targeted to help stop the bleed. So our topical therapies were oxymetazoline, which is formulated in the 0.05% nasal spray. And they applied this by using 2 atomizations or sprays from the nasal spray device onto a gauze pad, which is roughly around 0.1 ml, so not a lot of volume. But they took that gauze pad and then applied it straight to the affected nostril. TXA, they utilized 500 milligrams of TXA, and they diluted that with 5 mils of sterile saline. So thinking our normal concentration is like 100 milligrams per ml, so around a 10 ml volume. And they used the saturated gauze pad with that solution and applied to the affected nostril. And then on a similar theme, lidocaine and epinephrine, they use 1 milliliter of 1% epinephrine and then 1 milliliter of 2% lidocaine. And they saturated a gauze pad and applied to the affected nostril. So we'll briefly just review the mechanisms of actions of all the medications. So oxymetazoline is an alpha agonist. It mostly works on alpha-1, but it does have some alpha-2 properties, specifically indicated for nasal congestion, and it can be utilized over the counter for patients. They do 2 to 3 sprays into each nostril twice daily, and then that's max dose of 2 doses within 24 hours with a limited duration of 3 to 5 days, just due to the risk of rebound rhinitis. Has a relatively quick onset within 10 minutes and around a 12-hour duration of action, hence like the twice daily dosing. Obviously can be given nasally as well as topically through an ophthalmic solution or a topical cream as well. Rebound rhinitis is our biggest concern, especially with prolonged use, but not necessarily applicable to this trial. And then it can cause irritation to the application site as well as transient hypertension. So if a patient presents with uncontrolled hypertension, this might not be the best option. Tranexamic acid or TXA is an antifibrinolytic. Specifically, it prevents plasminogen, the plasmin conversion, which would prevents the fibrin platelet plug degradation, so it allows to form a strong clot. TXA has a whole slew of indications, and I tried to summarize them the best that I could. Hemoptysis, abnormal uterine bleeding, trauma-associated hemorrhage. A lot of it comes from uncontrolled bleeding. Dosing varies on indication as well as formulation. You can see that it's available in a solution in a 650 milligram oral tablet. So dosing will vary based on that. Unfortunately, onset and duration of action was not super well defined for topical administration, as well as the adverse reaction. So specifically thinking for IV infusion, if it's given too quick over this 10 to 20 minutes, actually hypotension can occur. And then finally, lidocaine with epinephrine, combo product, often formulated together in the same vial for ease of use. Lidocaine is an anesthetic that inhibits voltage-gated sodium channels in nerve cells, and then epi, which we're all familiar with, is a non-selective sympathomimetic, which would, in this scenario, result in vasoconstriction, which would be preferred to help stop the bleed. Dosing varies also relatively significantly, around 1 to 5 mLs initially, the discretion of the provider or how much they need to utilize in the specific area of concern. Generally up to 500 milligrams of lidocaine, which I believe is around 5 to 7 mg per kg. But again, that would take a decent amount of use to reach that dose. So preparations, there are a bunch of ones varying in lidocaine percentage, as well as epinephrine concentrations, as well as varying vial sizes. At UCMC, we just kind of use whatever we have. And we try to rotate through short dates since all the local anesthetics go on shortage very frequently. Generally well tolerated, can have some injection site burning, as well as this LAS, which is local anesthetic systemic toxicity. But this would only be of concern when we're really pushing the dosing limit. So looking at the study design, they screened 378 patients, of which they included 373. So out of those patients, the 373, 89 of them had successful pressure therapy, and the 284 received topical therapy at the discretion of the provider again. And this met their power. They had initially planned for 284 patients. You can see relatively split evenly between the groups, like a 1-to-1-to-1 ratio, if you want to think of it like that. Insert of the percentages here, which will also be echoed on the next slide, but around 50% in success for the lidocaine epinephrine and then TXA groups, and then slightly higher at 71% for the oxymetazoline group. And then these patients that were unsuccessful had failure to topical therapies and direct pressure therapy. ENT was consulted, and you can see that around 40% of those patients, 40% of the patients had posterior epistaxis. So looking at our baseline characteristics, this is, again, just the 284 patients that received topical therapy, so the ones that were unsuccessful utilizing direct pressure therapy. Nothing out of the ordinary here, in my opinion. Around 60 years old, majority of male participants. I did want to point out that there were around 25% across the groups that had prior anticoagulant therapy. So props to them for including that in a study that's about bleeding. Hemoglobin platelets within normal limits, and then INR, the TXA group, you can see slightly elevated, but in the grand scheme of things, within normal limits. So our primary outcome, which was percent patients that achieved hemostasis, you can see going from left to right here, which is 49% in the lidocaine epinephrine group achieved hemostasis, 55% in the TXA group, and then 71% in the oxymetazoline group. And you can see that they did the p-value statistics does suggest that there is this significant difference between this. And this significant difference exists only between the oxymetazoline and lidocaine group. So looking at it in picture form here, you can see on the far ends here, there's a relatively around 20-ish% difference, whereas there's no significant difference between oxymetazoline and TXA or TXA and lidocaine epinephrine. The two secondary outcomes that they looked at, so the top chart represents time required to achieve hemostasis. A little bit confusing, so I'll do my best to walk you through this. Each drug has its own little cluster of bars. So on the left, the blue bar is a percent of patients that achieved hemostasis within 5 minutes, and then 10 minutes, and then 15 minutes. So you can see here that oxymetazoline had the highest percentage within 10 minutes, and then around 20% more come in with around 30% more come in within 10 minutes total. So a relatively quick onset of action, and thinking back to the mechanism, that tracks pretty closely with around 10 minutes expected onset of action. And then TXA and lidocaine epinephrine have relatively quick onset of action, with both of these working within 10-ish minutes or so. So again, their statistics, they state that there is a significant difference between oxymetazoline and TXA, but there's no difference between the other two groups. And then finally, the last secondary outcome they looked at was the patients that achieved hemostasis, and then they were evaluated for recurrent visits within 72 hours. So you can see here that the lidocaine epinephrine group had around 31% of patients that had a recurrent visit, and then 26% in the TXA and 10% in the oxymetazoline group. So this suggests that there is a significant difference between oxymetazoline and TXA, and then oxymetazoline and lidocaine epinephrine, but no difference between TXA and lido with epi. And note that the group sizes are different with these, and this is only because the patients that had achieved hemostasis. So you can see that it's around like 50-ish% in these two based on the original sample size, and then oxymetazoline was at 71%. They did do a subgroup analysis based on epitaxis type. I mean, the majority of the patients had anterior epitaxis. 333 out of the 373 patients had the anterior epitaxis. So remember, if going back to the study design slide, 40 of the patients that failed topical therapy had posterior epitaxis, and that suggests that in this relatively small sample size, every patient with posterior epitaxis did not respond to topical therapy. Very similar results in this subgroup analysis. TXA and lidocaine epinephrine have a similar achievement of hemostasis, and then oxymetazoline slightly higher, and that significant difference again only occurs between oxymetazoline and lidocaine with epinephrine. So wrapping up here, my thoughts, I think to no one's surprise, direct pressure therapy should still be considered first line. That's how the guidelines recommend it. Again, I think it's like human intuition for us to, almost like a reflexive response to kind of squeeze your nose and help stop the bleed. I do think oxymetazoline, based on the results of the study, is reasonable to consider preferentially for topical therapy. Ultimately, I think there should be standard protocols for topical medication management within, each emergency department, within each health system, that kind of standardizes the algorithm that potentially providers would go through to order. So the authors concluded that, and this kind of goes back to the pathophysiology, that reduced effectiveness of pressure therapy and increasing age could be attributed to the vascular fragility that occurs in these patients. And then that oxymetazoline has a more rapid onset, more effective at achieving hemostasis, and had lower recurrent visits. So they suggest that it is more effective compared to TXA and lidocaine and epinephrine. So some strengths, I think they did the best they could at balancing the cohorts. So it was relatively 1-to-1-to-1 between the three topical therapies. I do think they utilized the correct statistical analysis to correct for the multi-group comparisons, and they were really transparent with where that significant difference lied. Some limitations, obviously not randomized, so kind of thinking of the pyramid of the strength of studies, this kind of falls right in the middle, being a observational cohort study. The biggest thing with me is that I know they standardized the way it was applied, but thinking back to the 0.1 mLs of the oxymetazoline applied to the gauze pad compared to like several mLs for the lidocaine epinephrine and up to 10 mLs with the TXA, it's hard for me to think that all of it's getting to the appropriate area in the nose when they stuff that gauze pad up into the nasal cavity. So just something to think through. The recurrent visits was evaluated in a relatively short time frame of only 72 hours. Fortunately, they did collect anticoagulant, but no antiplatelet use. I think that would have been interesting to see. And then they didn't mention too many tolerability data endpoints. So being all topical therapies, I would generally say it's safe to assume that they were tolerated well, but they did not report any of that. So in conclusion, nosebleeds are common. The majority of people will have a nosebleed in their lifetime. Direct pressure therapy applied to the nasal alae should be still recommended as first line. I think oxymetazoline can be considered first out of the available topical therapies. Then obviously we want to continue to engage our ENT colleagues where appropriate to help manage these patients. Huge shout out to Leslie and Melissa who helped me kind of review this presentation, and I am happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles and emergency emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.